the message to your classmate. Don't miss the session tomorrow. And then remember the quiz for next Friday. Okay. So if not, is Prof Henry here? Prof, have you been here, Prof? Because I tell him to come in a bit late. So Prof Henry haven't joined. Okay, yeah, just stay. Okay, you're here already, Prof. I'm done with the briefing, Prof. So I pass the mic back to you.
I just want to clarify tomorrow's lectures. It will just be one lecture, but 3 topics. So it may be over 1 hour. So maybe more than 1 hour, because I think that's the best way I can deal with it. So the 3 topics, I consolidate everything into one lecture, but maybe more than 1 hour. All right? Okay.
Okay. So this is last. So next week lecture will be this. Dr. Paul one start at 10:30. And then quiz will be Friday. And then face-to-face practical will be back on next Tuesday. Okay, I think that's all. Okay, thank you, Prof.
Yeah. Okay, good afternoon, students. Can we start with today's session?
Yes, Professor.
Okay. I share my screen. Can you see my screen now?
Yes, Doctor.
Okay. Phone. This is a 28-year-old lady who had been married for 4 years, trying for a baby, but had a recurrent spontaneous abortion. Okay, and she had been having 3 of those spontaneous abortion occurring during the first trimester of the pregnancy during the past 2 years. Hemoglobin is 12, white cell count of 3.8, platelet of 108. The prothrombin time is 14 seconds, APTT is 52 seconds, and the mixture studies on the APTT, okay, patient's plasma plus normal plasma, 50-50 ratio or 1-to-1 mixture, 48 seconds. Comment on the above results?
Hemoglobin normal. Total white cell count. Wait a minute. Slightly below than normal, I think. Platelet slightly below. Prothrombin time in normal range. APTT prolonged. APTT on 1-to-1 ratio mixture of patient's plasma and normal plasma prolonged.
All right, so not corrected. Okay, not corrected. So we have a lady with normal hemoglobin, but slight leukopenia and thrombocytopenia with a prolonged APTT, which is not corrected on mixing studies. All right, so what is the most likely diagnosis? She's got no history of bleeding. I forgot to specify. I forgot to mention it there, but she's got no history of bleeding. It's just she is investigated for recurrent spontaneous abortion. if you look at the abnormality first, okay, abnormality is prolonged APTT. So in which pathway is that coagulation factor if affected?
Extrinsic pathway.
Intrinsic pathway. Intrinsic pathway. Okay. So and what is it? Is it deficiency or is it inhibitor?
Inhibitor.
All right. So it's inhibitor. All right. Okay. So it's an inhibitor of factor in the intrinsic pathway. Now the other question is, I've talked just now about specific factor inhibitor. Okay, you can have factor 8 inhibitor, you can have factor 9 inhibitor. All right. Now there are inhibitors which is not specific to a coagulation factor, but inhibit something else. Okay. Example, it can interfere with phospholipid, which is a cofactor. Some inhibitors bind to phospholipid. Okay? And because it binds to phospholipid, it interferes with the coagulation protein activation. Okay? So this is an example in this patient. This is a patient who has lupus anticoagulant. Okay, there is an antibody which acts against phospholipid. Okay, and it causes problem in the interpretation of, because it inhibits your clotting pathways. But this condition is not associated with bleeding. In fact, they can have thrombosis rather than bleeding. Okay, and one of the presentation is like this patient, they have recurrent abortion because of this inhibitors. Okay, the other thing which is suggestive of lupus in this patient, okay, is this low white cell count and the low platelet count. Okay, because lupus is also associated with other antibodies or other autoantibodies, so they can have autoantibodies acting against the blood cells as well. In fact, some patients also can have low hemoglobin, but in this patient happens to be okay. Okay, so this is from somebody with lupus having lupus anticoagulant, okay, due to presence of inhibitor, which is not specifically against the clotting factors, but against the phospholipid. So further investigation, so you want to confirm that there is lupus anticoagulant, so you test for it. So you do at least 2 tests to confirm it. Okay, what is done usually is the so-called, you don't have to know details like this. I'm just telling you that there are ways of confirming this lupus anticoagulant. Okay, so you need to do a clotting time using silica rather than kaolin. Okay, and the other way is you have to do both because one is not enough to confirm. The other one is you use venom from this snake, okay, called Russell viper. So you do the clotting time using this Russell viper venom, okay. Then you'll be able to detect this lupus anticoagulant. You need to do other tests as well, okay, but the other tests are not hemostatic tests. So you need to do an anti-phospholipid antibody, okay, take blood and assay for the anti-phospholipid antibody. You also need to do anti-cardiolipin antibody and anti-double-stranded DNA antibody to find out whether the patient has systemic lupus erythematosus or not, because in a number of patients, they can have full-blown systemic lupus erythematosis causing the lupus anticoagulant. Some patients, lupus anticoagulant can be present without systemic lupus erythematosis. But you have to do this one, anti-double-stranded DNA antibody, to find out the patient whether the patient has SLE or not, because they require treatment. Okay, so this is an example to show you that prolongation of APTT, okay, can be due to inhibitor. So in mixing studies, they will not be corrected, but that inhibitor is not specific against a particular clotting factor. That inhibitor is against phospholipid, okay, which interferes with clotting. Okay, let's move on to case number 8. So this is a 51-year-old director, company director. He presented with easy, it's a male. So he presented with easy and spontaneous bruising on and off for 2 months. He said that he had been feeling unwell with loss of weight and loss of appetite during that period, that 2 months. He is a heavy smoker and chronic drinker, usually drinking whiskey and wine. That has been for the past 30 years. Examination, he looked unwell. He had pallor, mild jaundice, some spider nevi on the chest. Okay, so this term may be new to you, spider nevi. Okay. Spider nevi are abnormally dilated small blood vessels. Okay. When you press on them with your fingers, they blanch, meaning that you can stop the blood from there flowing. So they blanch. But you lift your finger after pressing it, you can see the spot again. So it appears like a red spot, a spider kind of a pattern. Okay, so that's why it's called spider nevi. So it indicates something. There were also purpura noted on the back of both hands and some old bruises over the skin and the arm. And he had liver palpable 2 cm below the right costal margin and the spleen palpable 3 cm below the left costal margin. Okay. So enlargement of both liver and spleen. Hemoglobin 9.2, white cell count 3.8, platelet 108, with MCB of 100 femtoliters. Prothrombin time 24, activated partial thromboplastin time 58. Comment on the above results?
Hemoglobin slightly low, white cell count slightly low, platelet count low, MCB normal, prothrombin time prolonged, APTT prolonged.
Okay. Right, so you see the blood count here. Okay, all of them are low actually. Okay, not very low. Okay, the total white cell count is 3.8. Okay, the lower range is 4, so actually not very low, but it's low. Okay, platelet 108. Okay, so I want to introduce this term. Okay, but it's probably what they call it. Not. I'm just introducing the term. It may not be connected to the case. Okay, but this condition, when you have low hemoglobin, low white cell count, and low platelet, we call it pancytopenia, PANCYTOPENIA, okay, pancytopenia. All the 3 counts are low. So this patient has pancytopenia, okay. Now the MCB, okay, the range that you are given, okay, 100 is the upper limit of the normal, okay. So this is upper limit of normal. All right. PT prolonged, APTT prolonged. Okay, so yes, so that's the comment on the results. So what is the most likely diagnosis? Anybody? As I said in the beginning, because you haven't done other blocks, so your knowledge for this one is a bit limited, okay, but never mind, you can try.
Is it liver disease?
Very good. So this patient had chronic liver disease. Okay, chronic liver disease. Okay, so these are the signs of one important sign here is spider nevi. Okay, you get this, quite typical of chronic liver disease. And also this patient had jaundice, palpable spleen, which is indicative of portal hypertension due to the chronic liver disease. All right. Yeah. So chronic, not acute liver disease. So you have to be a bit more specific. This is chronic liver disease. Most probably due to the chronic use of or abuse of alcohol. Okay. So what further investigation do you need to do to confirm the diagnosis? Okay, this one is a bit difficult for you because I said you haven't gone to the other blocks yet. So for this sort of situation, what we do is we do liver function test. Okay? So this is taking blood, and what is considered under liver function test will be you test for the serum proteins, which includes the albumin and the globulins, serum bilirubin, both conjugated and unconjugated. You also do aspartate transaminases and alanine transaminases, alkaline phosphatase, and gamma glutamate transferase. So these are considered under liver function test. In patients with chronic liver disease, you expect the serum albumin to be low, the bilirubin to be a bit raised, AST and ALT to be a little bit raised. Alkaline phosphatase depends. If it is due to obstruction, then this one will be raised. If it is not obstruction, it can be normal. Gamma GT can be raised. So those indicates that there is impairment in the liver function. Then you can also do ultrasound in the liver to look at whether there are any irregularities, the liver size. Okay, in end-stage liver disease, quite often the liver becomes cirrhotic. So you can see nodules in the liver on ultrasound. Okay, CT scan not always required, but you may require it in addition to ultrasound. And of course, factor V assay is a very good indicator of the prognosis. Okay, usually in end-stage liver disease, factor V levels will be quite low. So it's quite good for prognostic purpose. And if there is chance for liver transplant, normally we do factor V levels to find out whether a transplant is indicated or not, okay? Because that helps to prognosticate patients with liver disease. Now back to this patient. Okay, so what is the likely explanation for the bleeding tendency in this patient? What is the explanation for the bleeding tendency as well as this test here?
Low platelet.
Okay. Somebody said low platelet. Okay. Any more?
Prolonged prothrombin time.
So, how do you explain the bleeding in this patient?
Deficiency in clotting factor produced by liver.
Okay, deficiency in clotting factor produced by the liver. All right. Okay. Okay, so you have two offers just now. Which is more likely, you think? One is low platelet, the other one is deficiency of clotting factors produced by the liver. My question is, which one is more likely, or is it both? Both equal contribution, or is it one more than the other?
One more than the other.
Which one more? Which one caused the bleeding more? Is it the coagulation factor? Is it the platelet?
Coagulation factor.
Okay, yeah. If you remember from my lecture the other day, okay, if platelet function is normal, somebody with a platelet of 108, you don't bleed. Okay, you should remember one of the notes there. So in this patient, the most likely explanation for the bleeding tendency is the due to the impairment in the production of or in the synthesis of clotting factors by the liver, and there are several, okay, except factor 8 and VWF. Almost all the rest are actually synthesized by the liver. Okay, so that explains the bleeding tendency. Okay, case number 9. 42-year-old man found to have these results on routine screening prior to elective hip surgery. He had been well in the past with no past history of any bleeding. Okay, I probably didn't give you the white cell count in this one, but it's 7.2, okay, hemoglobin 14.8, and platelet count 279. The prothrombin time is 13 seconds. APTT is 52 seconds. Thrombin time is TT, not PT. There's a mistake there. So yeah, I didn't realize that. So this TT is 12 seconds. Because of APTT prolonged, mixing test was done, and it goes to within the normal range. So it means it is corrected. Okay, coagulant activity of factor 8 is 0.9. Factor 9 is 0.77. You are given the reference there also. Okay, so what is the most likely diagnosis? We have commented. So what is the most likely diagnosis? Which coagulation pathway shows the abnormality here?
Intrinsic.
Intrinsic pathway, very good. So intrinsic pathway, extrinsic pathway normal, and conversion of fibrinogen to fibrin also normal. Okay, so it means that you are dealing with 9, 8, 11, 12. So what's the most likely diagnosis?
Deficiency in factor 11.
Factor 12.
Okay, somebody said 11, somebody said 12. Okay. All right, so the correct answer is 12. Okay, but in the exam, if somebody put 11, I give some marks because I told you that factor 11 deficiency can have variable bleeding. Some patient very mild, some patient very severe, but the mild one, there can be no bleeding. So some one or two cases, occasionally no bleeding. So I do give marks if in this sort of situation. Okay, but the correct answer in this case is factor 12. All right, so it cannot be 8 or 9. Okay, this is if you are doing a MEQ, but if you're doing a best answer question, BAQ, there's only one answer, factor 12. If I put factor 11, 12, 9, 8, only one will get marked. Okay, but if you're writing a MEQ, 11 will give some marks, not full. All right. So this is factor 12 deficiency. So of course, to make a diagnosis, you have to do an assay. All right. My next question is, I haven't put it here. Okay. The surgeon was scared to operate on him because of this prolonged APTT. So he consult you. You are the hematologist now. Okay. You graduated already. You already went for your specialized training. So the surgeon consult you. So can I operate? That's his question. So what's your answer? Anybody already hematologist, you can answer. Pretend. No one wants to try.
Cannot.
Cannot. Why cannot?
Too risky.
Too risky. Okay, the answer is if you only have this result, okay, not yet, okay, you have to wait for confirmation. But once you have confirmed factor 12 deficiency, it is safe to operate. Okay, if it is not factor 11, okay, once it's confirmed factor 12 deficiency, it is safe to operate because the patient will not bleed. Okay, but before confirmation, if you just obtain this result, ask the surgeon to hold on. Don't operate yet, because factor 12 assay. I mean, you cannot do it right after the. Normally, this mixing test and all this initial investigation, one day will be taken by them. So then for you to do the next test to confirm it, the assay will take another day. All right, so you ask the surgeon to hold on until you confirm the diagnosis. Okay, so if it is confirmed, yes, you can go ahead. Okay, case number 10. A 45-year-old man is referred for further investigation following the finding of abnormal coagulation profile. He went to his GP because he had developed easy bruising and epistaxis. He has been having good health previously, except he had chest infection. Okay, not COVID. He had chest infection and was prescribed amoxicillin. Okay, few weeks before consulting before developing the easy bruising. So prothrombin is 45 seconds. Activated partial thromboplastin time is 79 seconds. Thrombin time is 12 seconds. Fibrinogen is 2.9 grams per liter. PT on the mixture 42 seconds. APTT on the mixture, 1-to-1 mixture, 73 seconds. Okay, comment on the results.
PT prolong, APTT prolong, thrombin time within normal range, fibrinogen within normal range, PT on 1-to-1 ratio mixture of patient's plasma and normal plasma, prolong, APTT on 1-to-1 ratio mixture of patient's plasma and normal plasma, prolong.
Okay. Very good. So the mixing test, both PT and APTT is not corrected. It shows no correction. Okay, so PT and APTT prolong with no correction. Okay, let's look at the possible differential diagnosis, meaning I'm asking a few. Okay. Anybody wants to try? First of all, look at which pathways are involved.
Intrinsics.
Intrinsic. Anything else?
Extrinsic.
Extrinsic. Okay, so actually both pathways involved. Okay, both pathways involved. From the history, okay, it is unlikely for this one to be something inherited. Okay, he has been well before. He developed this after he developed taking the antibiotic after the chest infection. Okay, so unlikely to be inherited. And also, when you encounter things like this, okay, there are several factors to be considered. It could be something wrong with several coagulation factors, or it could be something wrong with one coagulation factor which involves both pathways. You know what I mean? Okay, so these are the possibilities. Okay, as I said just now, it's most likely acquired, and because both are not corrected, APTT and PT, so most likely this is inhibitor against the clotting factors. All right. The other possibility is, could this patient be having vitamin K deficiency? Okay. With that sort of history, okay, has been well throughout. Suddenly, only after the chest infection, taking the antibiotics for that. So it's, again, this vitamin K deficiency is a bit unlikely, because vitamin K deficiency tends to be something a bit chronic. Okay, but this one cannot be ruled out. Although we have no history, there's no reason that for him to take warfarin, but it could be intentional. Somebody want to kill themselves, they take warfarin. You know that warfarin is rat poison. Okay, rat poison contains warfarin. Okay, so the rat die because of bleeding. So if you tell the patient who you give warfarin that they are taking rat poison, they will not take that medicine. But actually it is. Okay, so you just tell them that it is a blood thinner. Yeah, it is possible. Okay, but then you have to explore a bit more. So it could be he has been taking this, okay, on his own, not on any medical advice. The other possibility is could be disseminated intravascular coagulation, but normally in DIC, all the 3 times will be prolonged. TT, PT, and APTT will all be prolonged, but here TT is not prolonged. So that makes this one less likely. So we are left with these two here. All right. So these are the 2 possibilities. Okay, so this was done. Okay. All right, because when you have inhibitor involving both PT and PTT, it is very unlikely for inhibitors of 2 pathways. For example, inhibitor against factor 7, which cause the PT to be prolonged and not corrected, plus inhibitor against factor 8 or factor 9, which cause the APTT to be prolonged and not corrected. So it is very rare for 2 inhibitors to be present together at one time. So the prolongation of both the PT and APTT due to inhibitor is most likely due to one inhibitor which is in the common pathway. So these 3 factors are in the common pathway. So you have to think of inhibitors against these 3 factors. All right. So when you have an inhibitor against the factor, of course the factor assay will be low. So you want to do a factor assay for these 3. So if I give you this result, so what is this patient having based on this result?
Factor V deficiency.
Yes. So what is your diagnosis in this patient? This result shows factor V deficiency. So what is your diagnosis?
Vitamin K deficiency.
No.
Presence of factor V inhibitor.
Yeah. Right. Okay. So it's not vitamin K because vitamin K is 5 is not affected. Okay. Remember vitamin K 2, 7, 9, 10. 2, 7, 9, 10, not 5. So when you have low level of factor 5 like this, but the screening for inhibitor is positive here, both of this. Okay, so that factor 5 deficiency is due to the inhibitor. Okay, so the diagnosis is inhibitor to factor 5. Okay.
Doctor, may I ask,
Mm-hmm.
why didn't you guys check for the level of factor 1? Factor 1 is also in the common pathway, right?
Yeah, the level is here.
Okay. Okay.
Mm-hmm. Right, fibrinogen is factor 1. So this patient had inhibitor against factor 5. Now it is well documented in case records that somebody who has been taking antibiotics can develop inhibitor against clotting factors. Okay, factor 5 has been reported. Okay, so this is due to taking amoxicillin that triggers the body to develop autoantibody. Somehow the autoantibody acts against the factor 5. Okay, so this is not common, okay, but just to show you an illustration that as long as you are able to reason out and work out this one, you'll be able to determine, okay, what to do next, and you can come to the you'll be able to find the answer. Okay, so let's move on. Case number 11, another baby. This is a younger, 10-day-old, previously well, on breastfeeding, but was born at home, and at that 10-day-old was found by the parents to be unconscious and bleeding from the gums and mouth. Okay, but otherwise there's not much abnormal history from the mother. Noted that following the home delivery, the mother had a major bleeding, postpartum hemorrhage, and had to be sent urgently, okay, required emergency admission to hospital after the delivery. So that's the information that was obtained. The calculation screen showed these results: a PT of 102, APTT of more than 120. Normally, this one, the machine only recorded up to 120 seconds. If it's still not clotted after that, okay, the machine just put it more than 120. It doesn't bother to record anything more than that. Okay, thrombin time is 12 seconds. Fibrinogen is 2.1. Okay, comment on the result.
The prothrombin time is way prolonged than average.
Very good.
Activated partial thromboplastin time is also is prolonged way past the normal time. Thrombin time is normal, and fibrinogen is within the normal range.
Okay, good. So when you see results like this, okay, so when you ask to comment, I think it's good if you comment on it, you say grossly prolonged or something like that, okay, way prolonged, okay. So at least you notice that, okay, it's not just prolonged, but very, very prolonged, grossly prolonged. Okay, so it's good for you to comment it that way. It means that you notice that, and it has got some significant interpretation. Right, so what is the likely diagnosis, and are there any differential diagnoses?
Deficiency of factor 5, 10, and 2.
All of them?
No, either one.
Either
we need
one,
to do
okay.
further
All right.
test.
Okay, very good. Very good. Either 5, 10, or 2, and you have to do for the test. Okay, my next question is this, can you tell whether this deficiency is inherited or acquired?
Inherited.
Inherited. Okay. Anybody has any different ideas? Anybody thinks that it is due to some other deficiency?
Vitamin K deficiency, doctor.
Vitamin K deficiency, yes. Yes. Okay, any other possibilities? Okay. So if you just look at the result, then it could be inherited or acquired. Okay, but what makes it more likely to be acquired is the fact that the patient has been well. There's no history of any major problems in terms of illness or trauma. Okay, and suddenly it is so grossly abnormal. So in that sort of scenario, it is more likely to be acquired, okay, rather than the inherited. Because inherited in a patient who is quite well, normally the times are not that prolonged, okay, not grossly prolonged like that. Okay. In this case, okay, even though it can be deficiency, inherited deficiency of 5, 2, or 10, okay, but as we said just now, because of the scenario, okay, the gross prolongation without an eventful history, just a normal delivery, it is a bit unlikely. It's a bit unlikely, okay? So it is more likely to be vitamin K deficiency. Vitamin K deficiency, as you know, it causes a number of factors, okay? 2, 7, 9, 10. 2 is there. Okay, 9 is in a intrinsic pathway, 10 is also in the common pathway. So vitamin K affects the common pathway as well, because 2 and 10. All right. So this baby had actually what is called hemorrhagic disease of the newborn. Okay, vitamin K deficiency. So let's get back to this one. What is the reason you think that this patient had vitamin K deficiency, this baby?
I think it's because the mother had a major postpartum hemorrhage.
So how does it cause vitamin K deficiency?
From the breastfeeding?
From breastfeeding. Yeah, I mean, it can contribute. It can contribute, but if in normal babies, okay, it doesn't really end up in having gross deficiency like this. Breastfeeding can contribute.
Maybe it's because during pregnancy the mother took certain medicines. Maybe.
Not really.
Is it because liver cell immaturity?
It contribute. Okay, it contribute. Yes, breastfeeding liver cell immaturity contributes to the vitamin K deficiency. But I mean, all the newborns are like that. There's so many newborns are breastfed. Okay, a lot of newborns, including premature, have immature liver, but they don't develop. Not many people develop hemorrhagic disease of the newborn. So, how do you explain why this patient develop it?
Did the mother take heparin?
No, the mother doesn't take heparin, not warfarin also, not on anticoagulant.
Is it because the baby is born at home? Because usually the baby is given vitamin K after the birth.
Very good, very good. Actually, this baby, okay, the mother had postpartum hemorrhage requiring emergency admission. So when she was bleeding so much at home, everybody panicked. So the attention was given to the mother, and people forgot to give the baby vitamin K injection. Okay, so they thought that everything was okay until 10 days later when this baby developed this problem. All right, so yes, so the reason in this one is because no vitamin K was injection was given to the baby. Okay, actually the nurse who came there brought the vitamin K but didn't give. Okay. All right, so not given vitamin K at birth, okay, contributes to this one. Okay. All right, so case number 12. This is a 56-year-old woman, okay, who had suspected carcinoma of the bowel and is admitted for surgery. She had no past medical history and no past family history of significance. And this is the hemostatic screening preoperatively. So the PT was 14, APTT was 76 seconds, and fibrinogen was 2.9 grams per liter. Okay. Again, the findings you should be very familiar with. So when you ask to comment, you should know now that the PT is normal, APTT is prolonged, fibrinogen is normal. So which pathway is impaired?
Intrinsic.
All right, intrinsic pathway. So which are the factors which are likely to be involved? Intrinsic meaning from 8, 9, 11, 12, isn't it?
Yes.
Right.
Yes.
So 8, 9, 11, 12. Okay. So what other tests would you do to investigate the cause of this result? She had no history of any medical problems, nothing significant. Of course, maybe just everybody get flu now and then, okay? that's not considered significant. Okay, so there is no significant past medical history, no significant family history of bleeding. So how do you investigate this one? How do you proceed?
Will they do mixing tests?
Okay, very good. Okay, all right. If you trust the result, okay, you can straight away do mixing tests. Some people don't trust. Okay, different technologies doing so they don't trust you. Then you can repeat. So you want to repeat the APTT, still prolong. Then you do mixing tests. Okay, can you explain a bit more?
Do mixing tests to see if there's the presence of antibody towards the clotting factor inhibitor of intrinsic pathway.
Okay, so you do a mixing test to find out whether that prolonged APTT is due to factor deficiency or inhibitor. Okay, so you proceed that way, mixing studies. Okay, so if the missing studies is not corrected,
Means there's presence of inhibitor.
all right, so it means that there's presence of inhibitor. Okay, so let's say in this patient is not corrected, so you suspect there's inhibitor present. Okay, how else would you proceed?
Do the serum test level for factor 5 intrinsic pathway for factor 8, 9, 11 and 12.
Okay. You can do that. Okay, but if you do all of them at once, it's quite expensive. Okay. All right. So if you want to do this one, you can do one by one and see. You have to determine which is the commonest. So you do that first. Okay, which inhibitor is commonest? Okay, because factor 8 inhibitor is commonest, so you can do that first. Okay. Okay. But the other thing you do is also because this is a woman, so the chance of lupus is higher in women than men. So this could also be lupus anticoagulant, causing that prolonged APTT which is not corrected. Okay, so before you do the clotting, before you do the factor assay to find out whether this is specific factor inhibitor, it is better to, now I'm telling this, but because you haven't gone to this stage yet, so normally we confirm with the patient asking more detailed history. Okay, more detailed history of which things which could suggest that the patient may have autoimmune disorders. Okay, a detailed bleeding history again, just to confirm. All right, so we normally reconfirm the history. All right, so then you do the if there is anything suggestive in the history that this could be lupus, of course you do that. You do the screening test as we mentioned earlier. Okay. Otherwise, you proceed on to do the inhibitor for, the clotting factor level to find out whether there's specific factor inhibitor, like you said. Okay, so that's how we approach this case. For your information, this case turns out to be lupus again. Okay, lupus anticoagulant. Okay, this is the last case. So, 53-year-old man is admitted for inguinal hernia repair. He had history of prolonged bleeding after previous dental extraction and also bleeding after varicose vein surgery. Okay, varicose vein surgery is not really a major surgery. Okay, but varicose veins are under the skin. So what they do is they they use something like a wire to strip off the veins, varicose veins. So he developed extensive bruising following that varicose vein surgery. Okay, so his hemoglobin is 13.9. Now hemoglobin white cell count is 9.7, platelet 296. Mean platelet volume is 10.1, and the peripheral blood film shows no abnormality. Okay, normal, everything normal. The PT is 13, APTT is 32, TT is 12, fibrinogen is 2. Comment on the above result?
Hemoglobin level normal, total white cell count normal, platelet count normal, mean platelet volume within the range, peripheral blood film normal, PT normal within the range, APTT within the range, TT within the range, fibrinogen within the range.
Okay, so it looks like this patient had history of bleeding, but the full blood count results are normal, and the hemostatic screening test also appears all normal, isn't it?
Yes, doctor.
Yeah. Okay, I just want to explain a bit about MPV, mean platelet volume. So MPV is equivalent to MCV for red cell. So here you are looking at the platelet. The reason why we do MPV in certain cases is actually this is given by the machine actually. So when you do a full blood count, most modern machine will give you this value as well. It is important to look at this in patients with low platelets, okay, to find out whether the low platelet is due to reduced production or increased destruction. If it is increased destruction, okay, then you expect the marrow to respond by increasing platelet production, and when that is so, more younger platelets are produced into the bloodstream, so the MPV will be increased. Okay, so that's why we look at MPV. So in this patient, it is normal. So there is no indication that this patient is having increased platelet destruction. Right? Okay, so what maybe just give some suggestion. What are the possible diagnosis in this patient?
Is it factor 13 deficiency again?
Okay, factor 13 again. Okay, any more suggestion? Any more suggestion?
Nutrient deficiency.
Nutrient deficiency. So how do you translate it to bleeding? to causing the bleeding.
How about platelet function disorder?
Possible, very good. Okay, the platelet count may be normal, but they may not be functioning properly, and we are not testing, I mean, it's not tested in this screening test here. So yes, any more?
Vascular bleeding disorder?
Blood vessels. Okay.
Yeah.
All right. Okay. Any more? Again, blood vessel is not tested by this test, so it's possible.
It's said that the man was admitted for the inguinal hernia repair. And one of the factors that could facilitate the development of inguinal hernia repair is vitamin D deficiency. So maybe maybe it has a role in prolonged bleeding.
No. Well, vitamin D deficiency doesn't interfere with coagulation.
Doctor, this is
Yeah.
irrelevant, but will deficiency of calcium cause bleeding as well?
Deficiency of calcium. Deficiency of calcium in patients with what they call it, low calcium, they have more other problems rather than bleeding. Okay, although calcium is required as a cofactor, but normally the amount of even in patients with a bit low calcium level in the blood, normally they don't really interfere with the clotting mechanism. Okay, it must be very, very low for it to interfere with the clotting mechanism. Okay, so
okay.
Not the case here.
Doctor,
Yeah,
could it be mild von Willebrand?
very good. Very possible. Okay, so from the bleeding history, okay, this is more suggestive of a primary hemostatic defect rather than secondary hemostatic defect. Okay, if you look back at the words which we use here, okay, prolonged bleeding after dental extraction. Okay, that's why you have to ask the patient correctly in the history, okay? Because patient interpretation is different. Okay, so make sure that you get the correct history. Okay, not to confuse prolonged bleeding with delayed bleeding. All right, factor deficiency tends to cause delayed bleeding which appear to have stopped for some time because primary hemostasis is okay, but recur later. I give an example. They of delayed bleeding after dental extraction. And then you chew on the gauze. Okay, you go home, it feels okay. Bleeding apparently stopped, but several hours after that, okay, in the night you develop swelling, okay, and that's due to blood. So that is delayed bleeding. Okay, but prolonged bleeding is a bit different. the bleeding continue from the extraction. Okay, but once you manage to stop it, it stops. So the bleeding may take 12-15 minutes, but once it stops, it stops. So that is prolonged bleeding and not delayed bleeding. Okay, so this patient had prolonged bleeding but no delayed bleeding. Okay, so it's very important for you to ask properly the history. Okay, so if it is prolonged bleeding, it is suggestive of primary hemostatic defect rather than secondary hemostatic defect. Okay, so in this patient, it is very suggestive of primary hemostatic defect. So it is either due to platelet function disorder or von Willebrand's disease. All right. So in this scenario, if you think that the histine is not very accurate, if you think it's delayed bleeding, okay, if it is delayed bleeding with those normal tests like that, then of course you have to exclude factor 13 deficiency. Okay, but your history have to be clear. Right, so if it is primary hemostatic defect, which this patient has, it could be due to platelet abnormality or von Willebrand's disease. Okay, so these were done for this patient, okay, because of the possibilities of it being platelet function defect or von Willebrand's disease. Right, so this investigation were done, and these were the results. So what is this patient having based on this result?
Von Willebrand factor deficiency.
Okay, so it is von Willebrand's disease. Okay, so this patient has von Willebrand's disease. Okay, you know that in von Willebrand's disease, the factor 8 is also reduced. Okay, but the level, as I said, is not as low as in severe hemophilia A. Now, how do you explain this normal APTT? So von Willebrand's disease, you expect the APTT to be prolonged, isn't it? How do you explain it? It's not prolonged here?
Smile.
Very good. Yeah. Okay, so if it is mild deficiency, it may not be detected by the APTT test. Okay, I think I gave you indirectly the other day. Okay, so if you dilute, let's say somebody has 0 level of a factor, coagulation factor. Okay, you dilute that with you add normal plasma, so equal volume. Okay, the normal plasma contains 100%. Okay, So when you mix that equal volume, then the mixture will be 50%. Right? So 50% is still able to give a normal APTT, not prolonged. All right. So the level must be quite low for the reagent to detect. All right. So in some some reagents can only detect levels only as low as 30%, 30% and lower. Okay. So mild hemophilia may not be detected. Not all cases are detected. So that's why very important to have a good history, proper history. If there is definite history of bleeding, when you get normal results like this, either you have to repeat the test, or you have to do other tests. Okay. So here, even though it's APTT is normal, you still proceed on to do other tests, von Willebrand factor, lab antigen, and the platelet function test. All right, because of the sensitivity of the reagent. Okay, so may not be that sensitive. Okay, so I hope that has given you several examples of interpretation of hemostatic screening tests. As I said, some are easy, some are not that easy at the moment. That is because you haven't gone through other conditions yet, which may affect clotting factors activities. All right. So I think that's the end. If you have any question, you can ask now. Otherwise, we'll stop here. Any question? No. So can we stop here?